As Tom said, my name's Claire Haydon. I am a consultant occupational therapist and I work at Cheshire and Wirral Partnership and lead the adult autism team. I am also a clinic advisor to the National Mental Health Policy Team at NHS England and Improve and sit on the ARCOT England board. So I'm going to talk a bit about autism and how we as mental health professionals can support an autistic person's strengths, help them to address their needs and achieve their aspirations. So as Ian said, we often talk about autism in the context of being a disorder because that's what we classify in terms of the diagnostic criteria. But actually, there is a movement really trying to redefine that and looking at autism more as a neurodiversity. So this is a dictionary definition, which basically says that being neurodiverse is just a difference. It doesn't make anybody better or worse than anybody else. It's a different way of thinking and a different way of being. And therefore, it's really actually insulting when we look to try and eliminate autistic traits or people talk of a cure for autism, because for much of the time, autism is something that can be celebrated. So as Ian was talking about, the diagnostic criteria then looks at social interaction, communication, rigidity and repetitive focal interests, and then sensory differences. And what we can see is that actually all of these traits that are associated with the diagnosis of autism are actually just differences. So autistic people interact differently, they communicate differently, they might have different interests that are more intense, and they might have a different way of thinking about things, and they might interpret sensory information differently. And some of those differences can have positive impacts on a person's life and functioning, and some of those differences can have negative impacts. And unfortunately, because autistic people are different, and as Ian said, the prevalence is about 1 in 100, that if you're that sole person that thinks in a different way or sees the world in a different way, and you've probably been told lots of times that the way you're doing things or thinking about things or viewing things is different, then that can often be a negative experience. And working in an adult autism service, the majority of adults that we come across really have significant low self-esteem because of that difference. There are significant co-occurring conditions linked to autism, and there is some research that says specific autistic traits are linked to the onset of mental health difficulties and mental illness. So, for example, sensory sensitivities have been linked to making somebody mentally unwell, difficulties with social cognition, poor executive functioning, and difficulties tolerating uncertainty. But then there's those other factors that are external to the person that also can make them vulnerable to developing mental illness. So having co-occurring physical or mental health conditions obviously will be increasing a person's stress. Being autistic can have an impact on somebody's adaptive functioning. In a lot of the research that's been done around mental health and autism, and it has to be said there's not a great deal of research in that area, and it's certainly a priority for the autistic community to do more. But there is a sort of consensus that autistic people have a poorer or report a poorer quality of life than their peers. And there is also research to indicate that actually autistic people really struggle to gain and sustain employment, which clearly is very important for people's mental health, confidence and self-esteem. In addition to that, there is stigma, and autistic people face higher risks of being victimised, maltreated and are reported to have more adverse life events. In addition to that, as Ian said earlier around post-traumatic stress disorder, there is actually some research that says that autistic people are more likely to experience PTSD, even though those life events aren't in the diagnostic criteria or meet the threshold for the diagnostic criteria, probably because there's a build-up of different stresses or trauma in an autistic person's life often. And it's these negative life events that then provide the step from challenges to being autistic to somebody developing mental health difficulties. So there was a slide in Ian's around the AMAZE study. And there's also been a few other studies in the last couple of years, specifically looking at barriers for autistic people accessing mental health support. So I'll try and summarise some of the key points. So firstly, autistic people often find it difficult to recognise that they are becoming unwell or having difficulties, and then be able to seek support and communicate their needs. So in a lot of the studies, the sort of knowing that what's normal for you, and because autistic people report that they have got often poorer quality of life, that things are generally a bit of a struggle anyway, and it's quite then difficult to pick up if that tips into depression or anxiety, because life just feels hard. There is, as I said, a lot of stigma, and then there's communication difficulties and what's called alexithymia, which isn't just exclusive to autistic people. You know, we can see that anywhere, but that's where you can't recognize your emotions and be able to express your emotions to others. There's also a common thread throughout the literature that autistic people don't feel like they're listened to or taken seriously when they're trying to communicate distress. So feeling disregarded or like they're making a fuss about nothing. And there's probably a number of factors for that. Firstly, there is some differences in the way that autistic people communicate. And therefore, as mental health professionals, maybe we're not communicating effectively with them in understanding or empathizing with where they're coming from and how that might feel for them in the context of the rest of their lives. There's a lot of camouflaging amongst autistic people, and generally back to that idea that if you don't fit in or you've been targeted or bullied for being different, then there is a tendency to learn a strategy then to mimic or mask in a situation in order to blend in and in order to get by. Again, not an exclusive trait within autistic people, but certainly a strategy that a lot of autistic people will use, which can then make interpreting their communication quite difficult. We've then got issues with the basic accessibility of different services and mental health services, and especially if a person's got sensory sensitivities coming into an environment that might be new, unfamiliar, loud, busy, noisy, lots of people. If somebody has to get public transport to get to a place to have an assessment or any intervention, then that can be really difficult. And it is that kind of unpredictability as well, not knowing what to expect in that situation, which can be really daunting and often off-putting for autistic people. The problems with the availability of appropriate mental health services. So I know we've got loads of delegates here today from all over the country, and I'm guessing probably there's quite a lot of variance about what's available for autistic people, even within your patch, let alone across the country. And so, you know, you might not have dedicated support for autistic people or specialist services, or know about different support that's on offer, and that's been commonly reported that people get shunted from one service to the next, or they might get referred to learning disabilities services when they haven't got a learning disability, or excluded from services for mental health support because of their autism diagnosis, sort of that idea that, well, we're not commissioned to deal with autism, and therefore, you know, there is really no support out there for you. So in the literature, there's a lot of those experiences that are described, and it's quite common that people just don't know where to go, and and professionals don't know where to signpost people to. And then finally, the other consistent theme is that there has been a lack of understanding of what being autistic is like amongst health professionals. There has been limited training available for people. There's been a lot of misconceptions and myths. You know, it's only a couple of years ago where I was hearing people refer to an autistic person with a high IQ. Well, you can't possibly be autistic because you haven't got a learning disability. And I don't think that was an uncommon situation. You know, I think more and more we're recognizing and learning, and we're more aware of autistic people, and how actually autistic people are people, and the heterogeneity of that population. So a person is a person, and very different. But maybe it is unsurprising then, focusing on the suicide rates, that autistic people are 9 times more likely to die from suicide if they face lots of challenges in their life related to their traits. They face lots of challenges and stress related to sensory sensitivities. They often feel like the odd one out, like they don't fit in. They're often stigmatized and victimized, and when they do then try to access support, often that's not forthcoming. So we do need to change, because what is also clear in the research is that if an autistic person tries to access mental health support, but for whatever reason is unable to access that support or has a bad experience, then it makes them far less likely to try to access support in the future. And as a result, obviously not accessing support means a deterioration in their condition. So autistic people, in the study that Ian quoted, the AMAZE study, have said this is what would make mental health services better for them. And this was a Scottish study, so it's focused on Scotland, but I think looking at the rest of the literature, it's probably consistent throughout the UK. So they, you know, being able to actually access services, so not having services denied, taking into consideration their sensory and communication needs, taking their distress seriously, really important that, you know, that their distress, or if they're in crisis, that's validated, that someone says, you know what, that is, I can understand that you've got all these challenges and that sounds quite difficult. Again, not unique to autistic people. I think that's true for all. And having improved training of how we can support people, especially in a crisis situation. Sharing best practice, you know, having some of that guidance standards for services to get rid of some of that variance, so it's not dependent on where you're living in terms of what support you get access to, and having better post-diagnostic support pathways, which necessarily don't need to be within the NHS or the local authority. It's about, you know, as a system, third sector, voluntary sector, how do we provide that support, mental health support for people? Developing treatment with autistic people in mind. So, you know, we do need more research in autism and mental health. It is a priority by the autism community. And it's also, you know, we haven't got many validated tools to assess mental health in autistic people, or treatments that have been trialled within autistic people to see whether they're as effective or efficacious as, you know, as they would be in non-autistic people. And then all of us really, when we're planning our services and developing our services, try and involve autistic people in that change and in service development, so that they have a voice and they can help us make services that are more accessible and available for them. Crane and Davidson, Prosser and Pelicano then did a study and said to psychiatrists, well, what's the barriers to working effectively with autistic people? Although they realize that, yes, we need greater understanding and different ways to approach autistic people or be aware of their needs, there are also a lot of other things that need to happen. So, there are long waiting lists for people to get a diagnosis. The majority of autistic people that would present to your services won't have a diagnosis. So it's important to know the criteria and to make those reasonable adjustments anyway, really. There is limited capacity with the mental health teams, and not just for dealing with autistic people, but just generally. And it's really positive that in the long-term plan they're looking at increasing capacity with the mental health teams, and maybe we need to think about what that means for autistic people. There's a lack of clarity about the support that's on offer to autistic people locally, including diagnostic pathways. So are the pathways in your areas or support services in your areas well documented? Are they clear? And there is a commissioning gap, resulting in autistic people being not eligible for existing services. So, as I said, shunted back into and in between. So we can't address all of those issues in this training, but I think it's important to highlight that those issues are there and they do contribute to health inequalities faced by autistic people. But what we can do is improve the understanding of autism so that people can offer more effective mental health care and support. And wherever possible, you can advocate for more services or service developments to help autistic people access and have effective intervention. So one of the ways in which we can all develop our understanding or develop ways of working with autistic people really is by applying reasonable adjustments. Now, reasonable adjustments says what it does on the tin. It's really about what is reasonable. So what's reasonable for that person and what's reasonable for your service. So it doesn't mean that for all autistic people you must do X, Y, and Z, because your service might not have the capacity or might not function in that way. And for that autistic individual, that might not be what's required. So instead, it's about what can your service offer? So, for example, if an autistic person wants to see the same member of staff, they want to be seen in the same building or appointment room, and ideally want to be on the same day, is that something that's reasonable for your service or not? And then it's about compromising, well, what would be reasonable and how can we meet halfway in making this service more accessible for you? Going into lockdown, where we had our mental health services developing 24/7 crisis lines, we wanted to support our mental health colleagues in trying to think about reasonable adjustments when somebody's in distress or presenting in a crisis, because we felt that that would really help crisis intervention and help practitioners to just think through some of the main areas where reasonable adjustments could be applied. So we developed this, which is a check poster, and we'll share this because you'll be free to use it in your own area if it's going to be helpful for your mental health staff. But I'll go through each of the areas in turn and talk about reasonable adjustments for them. So firstly, communication. So it's really important to consider your communication with an autistic person, or as I say, somebody who you suspect might be autistic, and provide information in a variety of forms. So for example, some people prefer written information, both to present to a clinician to explain what's happened or how they're feeling, or to receive and then take back, because it will enable them to process that information after the event, especially if they're particularly anxious coming into an appointment setting, or it's the first time they're meeting you, because they might not be able to retain that information. Check that what you've communicated has been understood. So often, as I said, autistic people can mimic and camouflage, and sometimes they have scripts for how to be in a situation. For example, how are you feeling? Yeah, I feel fine, thank you. So it's really important that if you are giving information, especially if you're asking the person, to make a decision about information, that you check that they have interpreted you correctly and got the context of what you're saying and why you're saying and what that might mean. Wherever possible, ask really specific questions and be explicit in your instructions or expectations. Also, allow extra time for the person to process information and make decisions. So it doesn't always come naturally for us to have pauses when we're asking questions or in conversation. But it's actually really important to give a couple of seconds. And it kind of takes a bit of conscious effort in order to do that, to wait 5 seconds. It feels like a long time, but just like 1, 2, 3, 4, 5. That's quite a long pause in a natural flow of conversation. But that would make a really significant difference to lots of autistic people, to have that time to process information. Check that any humour, euphemism or metaphor is being interpreted correctly, and be aware of the potential literal interpretation of language. So idioms we all use at times. In fact, I used one I make a conscious effort all the time not to use them, but I said, it does what it says on the tin. That's like an idiom, which it can be really confusing for autistic people. I mean, why are you all of a sudden talking about tins? What's that got to do with anything? So just be really aware of what you're saying and that the person that you're with is understanding you correctly. Then check that you've interpreted the person correctly. So as Ian said, try not to make assumptions based on non-verbal communication, on intonation, facial expression or gesture. Often people use very considered and precise language, and some of the vocabulary of the people certainly that I've seen within our service is amazing, because one chap said to me, I can't just do chit chat. I find it really hard to describe how I'm feeling. So he's got very specific adjectives for describing, I think that's the right word, for describing how he feels about things, and for so that people are better able to understand him. But unfortunately, a lot of the time, while he's using this very formal and sophisticated language, it's sort of out of context or out of social context, and people just can find that really confusing if they don't have the same vocabulary, but also in the context of why is that person talking like that, or what does that mean? So really pay attention to the language, and if there's a better way of agreeing terminology between you for what that means, then that's again really helpful. Check, whereas we said before that you should check and see that you have been interpreted correctly. The same goes the other way. So check you have interpreted the autistic person correctly. Try to understand that an autistic person may struggle to identify or express their emotions or ask for help, and that's really common. Often people don't know how to ask for help. Part of it is that there's some people that might feel like they should be able to manage independently and they shouldn't need help. A lot of people in the network or the relation go to where they can seek help. And then otherwise, it's quite a difficult conversation to request help, and knowing how to do that in a way that's conventional and will be received and understood in the right way. So wherever possible, when you're doing crisis planning, try and incorporate that as to how would you ask for help, and how would you feel comfortable asking for help. Consider the atypical ways an autistic person might communicate distress. and offer strategies for allowing an autistic person to communicate when they are distressed. So, for example, within inpatient services, a lot of places use like wristbands for autistic people, where a different colour would mean that they are feeling distressed and they wanted support. They feel distressed and they need some time on their own. They might need some fresh air, and it kind of gets rid of some of those barriers of actually saying, well, excuse me, can I just get your attention? This is how I'm feeling, which is often very stressful for people. Another way that that works really well and has worked particularly in lockdown times is where people in families are spending a lot more time together in the house, and it can be overwhelming for some autistic people. And some of the people that I've worked with have generated a system or strategy where they use emojis. So they'll text emojis to their family members to say, just leave me alone for a bit, or I'm in my bedroom, you know, don't come in, or can I have a bit of your time, or can we go out please, or whatever that might be. Just obviously it's all very individualized, so whatever works for that person. The next one to check is about health. So all of us probably are a bit more irritable, a bit more stressed, have less tolerance if we're in pain. You know, if you think about if you've got toothache or something, but often autistic people don't experience pain as pain. They might not register that it's pain or it's an illness, and therefore it's worth exploring whether if somebody's presenting in crisis or in distress, it's just worth exploring that there isn't something else going on, that they're not in pain or they haven't got any underlying physical illness or mental health illness, in fact. And the hypersensitivity and hypersensitivity to pain is really important. So, for example, if you're doing a medical examination, you know, if you're doing a blood pressure or you need to take blood or something, for some people that can feel extremely painful, and they might respond in a, you know, in that distress. It might be very obvious that they're in pain or in distress, and that might be confusing. And for other people, they might not notice that they're in pain at all. So they might injure themselves and it doesn't register as pain, which is really important to know, because often people might not respond, for example, if they've burnt themselves or if they've cut themselves, and therefore if they don't get treatment or if the wound's not dressed, then people are more likely to get infection and more serious harm. But also if somebody that is coming to you who is hypersensitive to pain and then says, you know, I've got a stomach ache, and there's nothing non-verbally to suggest that they are in pain, they're more likely to be dismissed. However, if they are hyposensitive, then the likelihood is that stomach ache, if it's so bad that they're seeking help or speaking about it, could be an appendicitis or something else. So again, it's really about knowing the individual and how they experience things. And one way of doing that, so if there is, if you are working with autistic people, and I say it's not just for sort of looking at pain or physical health, it's really around everything. Using a My Hospital passport is really helpful to just think about reasonable adjustments. So asking the person how they communicate, how they would like you to communicate with them, how they experience pain and communicate pain, and generally, which is really important for most people, you know, what things cause you distress, what things are really difficult to cope with that increase your stress or prevent you from going to places, because that's what we need to address in our reasonable adjustments. How can we make the intervention with healthcare and social care less stressful so that you can access and treatments and interventions and get benefit from that? So there you can download the My Hospital passport off the NAS website, so autism.org, and you can do an electronic version. But in terms of our specialist service, so everyone who comes through us for a diagnosis, we would routinely give them a My Hospital passport. There is some guidance and notes attached to it, and we would encourage that that's shared with their GP. The next one is environment. Just check on time, right? So Consider the person's sensory processing and how it might impact on their presentation and functioning. So generally, we all process sensory information, and we all need the right level of sensory information to feel alert and attentive and relaxed. And at different times, it's obviously varies in different situations. But for autistic people, often their sensory differences, and people can have too much stimulation, so they'll experience senses too readily and become overwhelmed, and that can result in sensory avoiding behaviors. So for example, very frequently people report disliking a lot of noise. They're finding noise very difficult to cope with, so then won't go to noisy places, or will need to wear headphones, or need somewhere to retreat to. And working in those kinds of environments can be really difficult for autistic people if there are a lot of noise or different stimulation. And then for other people, there's not enough stimulation that can get them alert and able to function at their optimum. And so therefore they might be sensory seeking behaviours that they display. And that might be, you know, we all do it if we're a bit bored in meetings or training, maybe, you know, that you start to play with your pen or chew on the end of it, or, you know, chew gum or something else. And that's basically giving you some sensory input, enable to be attentive and concentrate. But these behaviours become really problematic when they interfere with daily life. So you stop going somewhere because of the sensory overload, or that then results in panic attacks or anxiety or shutdowns or meltdowns, or that, you know, people are often sort of unable to sit down. They feel very restless and fidgety, and are constantly needing some sensory stimulation. So if there is an occupational therapist linked to a specialist autism team in your area, then that is absolutely fantastic, and please utilise that. I mean, I would advocate that occupational therapy is one of the core disciplines you need in any autism services, but I'm an occupational therapist, so I might be a bit biased. But really, there is a wealth of input that they can give from a sensory assessment point of view, and really understanding the impact of the different senses. However, the reality is that there's probably limited occupational therapy input to your mental health services, and probably even less in terms of what occupational therapy access you would have from specialist autism teams. So instead, it's really just about being aware and asking the right questions. So for example, I was talking to a doctor who said, you know, they would not be able to cope or function on a daily basis if they didn't have strong smelling shower gel in the morning to give them that sensory input, or crunchy cereal, or doing a bit of exercise before work. Another person who was a researcher actually spoke about the only way he manages his, you know, he's very senior where he was work. The only way he manages his social life and his work life is to have enforced spaces in between, which are very low sensory stimulus spaces and time, where he can then recover and get over whatever activity he's had and prepare for the next activity. So it's about spacing it out. The other thing to be aware of is around the other three senses, so proprioception, vestibular sensory stimulation, and interoception. And interestingly, interoception is really important because often autistic people will report that they don't feel hungry. They might not get that feeling or feedback that they need to go to the toilet regularly, or that they need to drink. And for some people that can be really distressing, especially that you know, some people can have can be incontinent or have accidents in that way, which is really debilitating in terms of the person's functioning, because they feel like, you know, the naturally increases anxiety, as it would for most people. So it's about almost enforcing that structure and putting that routine in for those people. But it is important just to think about those sensory differences. And in terms of your interventions with people, then there's some really simple ways that you can make the environment less distressing for people. You know, so asking if a person prefers to have the light on and off, or the blinds opened or closed, or if they're wearing sunglasses, you know, just say, well, it's okay, you can keep you can keep them on, you don't have to take them off if that's making the environment less stressful for you. Ask people if they like to shake hands. Sometimes I think we presume that because it's social etiquette and that we would shake hands naturally, but some people can find that really uncomfortable at any touch. And almost at the first point of somebody coming into mental health services, and when you're thinking about a risk assessment, it's really important to ask, actually, what are your preferences around touch? Because if they were in a situation where they were in distress, or presenting in a crisis, or needing admission to an inpatient unit, it's actually really important to know whether you can put your arm around someone and comfort them or touch them, or whether that's going to exacerbate their distress, or they're going to, you know, find that extremely distressing. So another thing is noise, which again, I said a lot of people can find sort of background noise, so the noise of the computer, almost the heater, different fans can be really distressing for people. And some of those noises in the buildings that we work out of, you might not be able to eliminate. So it comes back to, again, about what's reasonable and what's not reasonable. And it just might be around saying, well, I'm really sorry about that heating noise. That's just the way it is. But maybe if I turn the computer off, that's one less noise to deal with. Or, you know, and especially important that if you have fire alarms, so certainly within our trust, it's on a Thursday morning, and you're seeing that person on a Thursday morning, do let them know that there's likely to be a test, or they might to be interrupted, because that unexpected noise can be very distressing for a lot of people. Smells, again, might have a limited control over. Sorry. Wherever you're working out of your buildings, but in inpatient services, often there are things you can do to eliminate smells or minimize smells. So, for example, if somebody's bedroom's right next to the dining area or the kitchen, you know, or the bin store, whatever, your clinic room, there's a lot of cleaning products, then you can make those adjustments and move somebody further away from that. Taste. So often, again, in inpatient settings, especially around food, and often people have quite strong preferences around the foods that they will eat, and strong aversions to other food. And often that can be a really difficult conversation to have, especially if they're in mental health distress or they're inpatient because they're not well. So asking those questions around food and food preferences is often really important. And people might have issues with taking medications. So that's important to know, sort of swallowing tablets and things like that. And then temperature is important as well. So some people prefer to keep their coat on, other people might feel very hot most of the time, so they might want a window open, and it's just checking what would be preferable for them. And all of these things will just enable people to be able to concentrate and engage with you the best that they're able to, without feeling overwhelmed or stressed. And what we would always say to autistic people, certainly coming within our setting, is to say, you know, don't worry about giving me eye contact. Don't feel that pressure to give conventional eye contact and look at me, or respond with your face in the way that you think you should respond. And if you want to fidget and tap, or even look at your phone, which, you know, often would be seen as socially inappropriate or unconventional, and it would suggest somebody's not listening to you, then we would say, well, look at your phone. If that enables you to then focus on our session, whatever you can get, however you can engage best and work with us, and is less stressful for you, really. So the next one is change. So change, especially unexpected change or changes that are outside of the person's control, can be really distressing for a lot of people. So sometimes it's big changes, like losing a job, or changing a job, or losing a relationship, or losing support from someone, or a house move or a transition. Those things affect most of us in some way, you know, and while some of us embrace that change is a good thing, as some autistic people would think that that might be the case, for a lot of autistic people, change can be really, really difficult. But there's also small changes or unexpected changes. When things don't go to plan, that can also cause a lot of distress. Or if there's a number of different changes at once that then build up almost into a big change, can cause a lot of stress. And then when there's recurring changes, so when there's inconsistency or a lack of predictability, well, that can cause a lot of anxiety and stress too. And if that inconsistency is unjustified often, then a lot of autistic people can get quite cross and frustrated about that because it's unfair. So, for example, a teacher or a lecturer at university setting work and saying, well, these are the rules, you must submit your assignment on this day and you must do that, and that's the rules. And then there's, oh, all right, then Simon, you can you can submit yours on a different day, or yeah, we'll give you an extension here and maybe you don't have to do that bit. And to an autistic person who might not understand that wider context, to some of those differences, that can be really sort of frustrating. And I've worked with a lot of people where that sort of sense of injustice has almost become all consuming. So people like need to put it right, you need to get justice for that sort of unfair system, you know, fighting the system almost. And in terms of our services and mental health services, we need to sort of reduce uncertainty wherever possible and inconsistency. So ensure that roles and rules and expectations are clear and consistent. Make sure you and your service keep your promises and don't promise what you can't deliver. And I think Ian mentioned that before, you know, certainly don't say, well, don't worry, we'll come to your house tomorrow at 10 a.m. and it will be me and my colleague and we'll do this. And then tomorrow at 10:30, two different people turn up and do something differently, because automatically that person's going to think, gosh, why have you lied to me and told me a complete different scenario? And then they'll be quite mistrustful of you going forward. So it's really important to keep your promises and only be very certain if you can absolutely ensure you can deliver what you're saying. And in terms of consistency, think about the person's treatment plan or their care plan. Is it explicit and consistent? Can it be delivered if you're off sick or you've moved jobs or there's locum staff or bank and agency staff? And you might probably need to give a bit more consideration to that than non-autistic people, in just ensuring that it's very clear what you've set out to do is going to be continued in that consistent way. And wherever possible, if there are going to be changes, because there's always changes that are outside of our control, or new activities, or a person's going to have to meet a new person or do something a bit differently, then wherever possible, give the person time. Let them know in advance. Let them plan and prepare for how that's going to be. And if possible, give them a lot of details about what to expect in that situation to try and alleviate some of that anxiety. We do make mistakes, us humans, and it's really important then to be upfront and honest about that as well. So if we do, almost back to that point around that sense of justice, if we do make a mistake in a person's report or on their notes that are shared with them or within their care plan, it's really important to be upfront and honest and say, well, do you know what? I might put wrong information into your notes, but I will always listen to when I've gone wrong and we can change it. Nothing's sort of undoable, if you like. We certainly do that within our diagnostic service. Every report that we write is sent to the autistic person in draft form. They have a chance to make any corrections or clarifications, and then they return it to us with the corrections before then we finalize the report, so that they know nothing inaccurate is going to be stored about them or inform sort of clinical judgment. And wherever possible, being forewarned is being forearmed. So provide advanced information in appointment letters, or if you've got a service website, let people know what they might expect, even down to who they might see, what kind of questions they're going to be asked, how long the intervention is going to go on for. If a service you're only going to see people for 10 sessions or something like that, it's really important to be upfront and honest about that from the off. What an intervention might consist of. So if you're inviting them for an appointment, or you say, well, next time we're going to do that, give a bit more detail about what that might be, because if people are unsure or uncertain, they might not attend their appointment, which would, is a waste of resource, a waste of your time, but also means that they're not getting the intervention that's going to be helpful to them. Often people will do a lot of research about things that they are concerned about, so if there is an evidence base or a rationale for why a specific intervention is being used, then provide that. Be really honest about waiting times. Again, if somebody's been referred to the service and the waiting list is 6 months, then tell the person that the waiting list is 6 months, and you can't be exactly sure of when their appointment might be, but you'll be back in touch in 4 months to let them know. And it's generally just knowing what to expect, and knowing when they'll next get some information. It's worse to say it's going to be 6 months and we'll see you on this date, and then that's changed for whatever reason. So honesty is really, really important, and that transparency. And then if an appointment is going to be delayed, offer them an option to leave and come back at a later time, because often waiting in a waiting room is really, really difficult. And then the last one is knowledge. So as I said earlier, when we were talking about neurodiversity, if you've met one person with autism, you've met one person with autism. Knowing the person is key. And each individual is really, really different. So they might have traits that sit under those headings for a diagnostic criteria, but actually for them, some of those traits be really positive. Some of those traits will present them with challenges, but in what circumstances and who is the person and what's their baseline is really important to know. Routine and quiet time is often important for people, so try to limit the disruption to a person's routine. And again, it's whatever's reasonable. So you might not be able, if someone's got a fixed routine from 9 to 5 and your service is a 9 to 5 service, well, then you can't see them in the evening if that's not the way that your service works. But there might be some negotiation of, well, what's most important that we don't disturb. Could I see you in the afternoon or in the morning, or and just an awareness of those routines and the importance of them. Ensure there's enough low stimulus or quiet time in a person's routine. So a lot of activity where there's a lot of sensory information often, or there's an expectation to communicate or interact with others, can be absolutely exhausting, especially when you're thinking about communication and interaction, because some of those communication differences don't come naturally to autistic people to read nonverbal communication or give conventional eye contact, or to pick up the wider context to what somebody might be saying, meaning, or intending, or noticing how somebody feels and being able to respond in a conventional way to those feelings. And because often autistic people have really low self-esteem because they've felt different, and they felt that information doesn't come readily to them, or they've been told they're different, then often these situations can be really stressful, and people will really concentrate and try to keep up with the conversation and put a lot of conscious effort into it, which means that after a social interaction, especially meeting somebody new, they can feel absolutely exhausted and just need to recover. So with that in mind, what you wouldn't want is an appointment in the morning time with one professional and then to attend a group session, for example, in the afternoon, because it gives them no recovery time. And as I say, not everyone. So some people might cope with a lot of different appointments or whatever activities in their schedule. So it's just about being aware for that individual what's going to be most helpful. And if a person is in acute distress, is there somewhere that's quieter where they can be on their own to recover? You know, so in an outpatient department, is there somewhere they can go? In an inpatient ward, is there somewhere where they can go? And often people will say, I just need that time on my own. And I think as caring professionals, we always feel like we've got to be there and got to support people. And for some people, again, that might be really helpful. But for some people, they might just need some time on their own just to recover. So it's about asking the right questions about person's preferences. As I said, the hospital passport, people often have a one-page profile. And if there are known reasonable adjustments, put that on the electronic health record so it's there as an alert. So if they present in crisis or to a new service, you can see that when you go into their care record. Record any trauma-related information, so that is easily accessible too. It's really re-traumatizing for anybody to have to relive sort of abusive or situations where they might have been exploited. So, you know, try and avoid having to make people repeat themselves wherever possible. If there is a recent diagnostic report, try and have a look at that, see from that report what traits are important and the impact of those and their strengths, needs and aspirations that you can work to. And if there is an informant, if there is a relative or a friend or a colleague that knows them well and the person's consenting, you know, try and get a different perspective to understand who that person is. This is around risks, because working in mental health services, obviously we have to think about different risks and consider some of those autistic differences when thinking about risks. So, you know, obviously unintentional harm to self, people might self-neglect. They might not prioritise activities of daily living over interests or other activities. Often autistic people will have what's called a spiky profile. So they're interested in something, they're really sort of skilled, they put a lot of time and effort into it. And if they're not interested in something, they just won't bother at all, which is a problem if you're really not interested in paying your bills or something like that. Some people develop maladaptive coping strategies, especially, you know, where there's significant low self-esteem, such as substance misuse or alcohol misuse. So that kind of feeling that you need something to be in a social situation. Some people might have deteriorating physical and mental health due to some of those barriers we discussed in people being able to access services for their health needs. Harm from others. Often we hear of autistic people being quite vulnerable to abuse, exploitation, bullying and harassment. That can be worse when, you know, autistic people do want to be sociable. It's a myth that they're not sociable and they don't want friends and relationships, and sometimes not picking up on those ill intentions of others or believing that everyone's going to think in the same way that they do can make people vulnerable, because they want to belong, they want to be part of the gang, and they might do things that someone asks them to do because they want to belong in that gang. So, you know, maybe a specific issue in sort of teenage adolescent services. And misunderstanding and miscommunications obviously can lead to arguments or altercations. Harm to others, really around, you know, don't touch people. Often that can lead to meltdown or somebody lashing out because they just a bit sensitive to touch. Misinterpretation, and meltdowns can also result in damage to property. So where someone's so frustrated at everything, they might then start punching walls or smashing windows or whatever else as a means for relieving some of that stress, especially actually if they're not able to express their emotions or frustration very easily. And that might be an area for work. And then harm to self. So Ian talked a bit about deliberate self-harm, but some people might self-harm as a means of a repetitive interest or a sensory activity as well. So it's trying to understand that to offer alternatives, and suicide, which we know is really significant factor in autistic people. But being autistic and having autistic traits, and where those traits have negative impacts, doesn't mean that that's it and that's just the way it's going to be. You know, we know that we can address mental health needs, and there's a lot of different therapies, but in the same way, you can minimize the negative impact of autistic traits and help somebody to achieve their aspirations. Loads of different ways that we can work with autistic people. I mean, generally, if they're presenting with mental health needs, you work in the same way anyway and just make some adjustments, but specific sort of therapies or interventions around the negative impact of autistic traits or sensory sensitivities, you know, anxiety management, focusing on the practical stuff, looking at distraction, breathing techniques, graded activity, try to address that avoidant behavior wherever possible, where people get more and more restricted in their lifestyle. Look for patterns of distress. So is there a certain day of the week or a certain sensory environment or certain individuals? You know, lots of people that I've worked with get very distressed in the early evening because they've had a lot of different stresses throughout the day that they haven't necessarily registered as stresses, and then it just all of a sudden feels very overwhelming in the early evening. So trying to work with somebody to recognize distress, or when they're getting distressed, to recognize the differences in their emotions and being able to express them, it's actually really, really helpful for people. And then looking at strategies for managing that distress and preempting situations that cause distress, and putting those strategies in. So it's almost like forward planning and contingency planning, which actually most autistic people do already, but it's just giving that professional support to, well, if you're going into that situation, these are the things that perhaps you need to build into that contingency plan or that way of coping. Often autistic people can be very critical of themselves. They might have rigid thinking patterns at times, which are kind of very concrete, where it's all or nothing. Therefore, perfectionism is quite common amongst autistic people, where they feel like they've got to do their best or everything else is rubbish. And obviously, we can't always achieve everything perfectly, which means that can sort of exacerbate low self-esteem if that's not addressed. So it's about trying to reframe some of those thoughts and enable people to give themselves compliments for sort of smaller goals, really, and doing a bit of graded activity around that. Look at different ways of communicating, as I said before, you know, different means. So by sending texts or using wristbands or pictures or anything else, because it's important that families are able to communicate together. When we've done diagnostic assessments, and interestingly, we've had a few that have come to us who are retirement age, and all of a sudden spouses are spending a lot of time together at home, and therefore some of those issues are coming to light, and this kind of, well, she doesn't care because she never notices when I've had a bad day, or wouldn't know that I'm upset, and doesn't respond to me in that way. Well, sometimes that can be really difficult for autistic people. So, you know, some of those strategies might be, if you've had a bad day, tell me you've had a bad day, tell me what's going to be helpful and what I can do, but just don't rely on that innate ability to pick up on those cues, because I might not be able to do it, but it doesn't mean I don't care. And some of those things can really help in relationships. And then finally, the use of technology and alarms. So sort of enforcing some of that structure where it might not come naturally, so that people can keep on top of their ADLs, you know, and keep on top of their housing and maintain tenancies and do the things that are necessary in work and health, and make sure that that routine is really balanced. If you're not sure of what to do, you know, check out, is there an autism team that can advise in your local area or your local trust? Do you have any intranet or internet resources on autism? And actually, as part of this training, we're developing a resource on autism that you will all be sent a link to, and we'll be asking our feedback from this training whether there's anything specific you want us to cover in that. So you will have some resource, but there might be other resources within your local organisations. And are there local groups that autistic people can benefit from that you can signpost families to, or third sector groups that you can link in with to make to offer different sort of mental health support in your area? And ultimately, what we want to do is use a strengths-based approach. So as Einstein says, everybody is a genius, but if you judge a fish by its ability to climb a tree, it will live its whole life believing that it's stupid. Autistic traits do have positive impacts. Autistic people do have a lot of strengths that are related to their autistic traits. So, eye for detail, being able to focus and concentrate, being really determined to, follow a goal through because that's the plan that they're going to stick to. That strong sense of justice, that's really important. Often autistic people are really good with following rules that make sense. I'm really good at pointing out where rules don't make sense and they're just there for rules' sake. So there's a whole load of skills that's related to being autistic, and we need to be able to support people to recognise those strengths. Another one is creativity. I think somewhere back in time it was said that autistic people aren't creative, they're not imaginative. Well, certainly the ones that I've met are very creative and very imaginative, and actually are often more creative because they see the world in a different way. So what we want is for autistic people to be successful autistic people and not feel like they've got to fake it being neurotypical. And we as professionals need to make sure that every contact counts. So we need to be able to help somebody to recognise their strengths, to work towards their aspirations, because if somebody has enough self-esteem and confidence, then they can ask for clarification if somebody is communicating with them. They are better able to say, well, actually, can I have these reasonable adjustments, or would you please do this for me? And then ultimately, if they're then in trouble, then they are better able to ask for support when they need it. And whether that's support as in, oh, can I just have support with this or that, or whether that's support, I'm really in crisis and I'm really not mentally very well, can you help me please? But that's really, really important. It's one of the biggest things that we can do for autistic people, is to recognise their strengths and support them to achieve their aspirations.